Consider the rules related to physician supervision. Physician shortages are a reality in many parts of our country. Rules that change the way routine therapeutic services are handled in rural areas, or rules that bar physician assistants providing services like hospice, disrupt access and the continuity of care for rural beneficiaries. We can do better. We must do better, and we will do better. We should provide relief for all of our hospitals and providers from overly burdensome regulations and bureaucracies. There's no better place to start that process than with the rural hospitals. There's much to be done, and today we're lucky to have here firsthand accounts from providers serving rural communities. First, we have Shannon Sorensen, a CEO of Brown County Hospital in Ainsworth, Nebraska, and a constituent of Mr. Smith's. Next, we have Tim Joslin, the CEO of Community Regional Medical Centers in Fresno, California, a constituent of Mr. Nunez's. Then we have Carrie Saya, CEO, there you are, CEO of Holton Community Hospital, facility located in Congresswoman Jenkins' hometown in Kansas. Finally, we have Dr. Daniel Dirksen from the University of Arizona. We're very happy to have you here today. This is the latest in a series of hearings held by the Health Subcommittee in the wake of the passage of legislation to fix the way Medicare pays our nation's physicians. Now, I know we mentioned this at our MedPAC hearing last week, but it stands repeating. We're in the midst of a great opportunity to reform how Medicare reimburses hospitals and post-acute care providers, all critical to saving Medicare for the long term. I hope today we can make progress in understanding the concerns facing those in rural areas. And before I recognize the ranking member, Dr. McDermott, for the purposes of an opening statement, I ask unanimous consent that all members' written statements be included in the record. Without objections to order, and I now recognize Dr. McDermott for his opening statement.
Thank you, Mr. Chairman. I want to thank the witnesses for coming this morning. I look forward to hearing what you have to say. I believe there is room for us to work together to address how we deliver health care to people who live in rural areas. I also believe that if we're going to have a serious conversation about this topic, we need to get the facts straight. To address the needs of rural communities, we also need to have long-term investments in our professional workforce. The United States faces a growing shortage of physicians and healthcare providers. That's nurse practitioners, PAs, all the people that provide care in rural areas. And it's projected to reach in physicians alone by 2025 between 46 and 91,000 people short to provide what's necessary. Rural areas are going to have a particular scarcity of physicians. We've tried lots and lots of things in the WWAMI program, but we continue to run into some of the same problems. Now, we should be skeptical that the solution to the problem lies in gutting Medicare support for graduate medical education in urban areas. There's minimal evidence whatsoever that this will result in more doctors practicing in rural areas. It will simply exacerbate the nationwide doctor shortage and lower the quality of training. There are better ways to train physicians to serve in rural areas, and I've encouraged my colleague to look at some alternatives. The University of Washington has run the WWAMI program, as I mentioned, which trains physicians not only in the cities, but out in the rural areas. They're placed out in little bitty places, and they see what it's like, and they learn what's necessary, but getting them to stay is tough. The program is finest in primary care and rural in the whole country, and has ably served the communities in Washington, Wyoming, Alaska, Montana, Idaho for more than 4 decades. But there's some other investments I believe we have to make if we're really going to deal with rural access. We can treat the medical profession like we treat the armed services and provide ROTC-style medical school scholarships to doctors who agree to a tour of service in underserved areas. I call this RDocs, and I believe it's a smart investment. We don't think there's anything wrong with giving somebody a college education and then keeping them in the Navy or the Army or the Air Force for 5 years. Why don't we do the same thing with medicine? Get somebody to sign a contract up front. I'll take the scholarship, but I'll serve 5 years as a result of that. Now, that's the only way you're going to get people out there for a long enough period for them to decide, maybe I want to stay here. That's the real problem. And moving forward, rather than attacking our existing programs and putting urban areas against rural areas, as we're going to do with this GME and IME and all the rest of it, I invite my colleagues to consider alternatives that will make a meaningful difference in rural areas. I yield back the balance of my time.
Thank you, Dr. McDermott. Really excited having witnesses today. We think there's some common ground on areas like this that we can move forward on. And so, Mr. Joslin, you're recognized for 5 minutes.
Thank you, Mr. Chairman. Ranking Member McDermott and members of the subcommittee, my name is Tim Joslin, and I am the Chief Executive Officer of Community Medical Centers based in Fresno, California. I appreciate the invitation to testify today about rural healthcare disparities and the role of federally funded graduate medical education known as GME. Community Medical Centers is the largest healthcare provider in California's agricultural heart, the San Joaquin Valley. We are a not-for-profit public benefit corporation operating 4 hospitals: Community Regional Medical Center in Fresno, Clovis Community Medical Center, Fresno Heart and Surgical Hospital, and Community Behavioral Health Center. Community Medical Centers accounts for 1/3 of all inpatient discharges in the 5-county region. We run a Level 1 trauma center, a burn center, and an ambulatory care center. We are also the largest provider of inpatient Medi-Cal services and uncompensated care in the region. Our downtown Fresno emergency department is one of the busiest in the state, with some 114,000 visits a year. We provide all of this with the help of about 300 medical residents and fellows from the UCSF School of Medicine. But our challenge is unique and daunting. The rural San Joaquin Valley, though rich agriculturally, is very poor economically. 25% of residents live in areas of concentrated poverty, making it the 5th poorest area in the country. In Fresno County alone, 1/3 of all children live at or below the poverty level. About 20% of Fresno County residents do not speak English, and 1/3 of adults have not obtained a high school diploma. The entire area's population has significantly higher than average rates of asthma, diabetes, and obesity. Nearly 1/3 of the population qualifies as obese, for example. The valley also has a higher than average incidence of chronic lung disease, likely due to its well-documented air quality issues. To make these sobering statistics even worse, the San Joaquin Valley suffers from a doctor shortage. The valley has 48 primary care physicians per 100,000 residents, well below the minimum recommended level of 60. If need is the measure, our region of the country should have more physicians per capita, not fewer. Graduate medical education is the key to solving this inequity. Community Medical Centers collaborates with the University of California, San Francisco to support the training of graduate medical students. We currently support some 250 medical residents studying in 8 areas, including primary care and emergency medicine, and we support 50 fellows studying 17 medical subspecialties. This GME program is a critical feeder to the region's entire physician population, and we'd like to grow the program. We are constrained, however. Our Medicare funding for GME positions is frozen at a 1997 level. Community Medical Centers has expanded the program on its own beyond what Medicare funds by investing well over $400 million over the last 10 years. But considering that Community Medical Centers now shoulders more than $180 million in uncompensated care each year, the ability to expand our GME program on our own is financially limited. And this, in turn, limits our ability to provide our region's residents access to health care now and in the future. In a region where the need for physicians is perhaps the greatest in the country, we are at a disadvantage under the current federal system of allocating GME slots. Yet our ability to expand access to physicians is highly dependent upon the GME program. As the Institute of Medicine's recent report noted, the location of one's medical school and GME training are predictive of practice location. Our own experience shows this. Close to 30% of our trained residents remain in the region to practice medicine. The current GME allocation criteria and caps have led to significant geographic disparities, as noted in a recent Health Affairs report, and are most acutely felt in our region of California. For example, our region's population has increased by 1/3 since 1997, yet our federally funded resident positions have remained at the 1997 level. This contributes to the disparity we see in the ratio of physicians to population. Community Medical Centers supports not only the expansion of GME, but equally critical, better allocation of GME slots to underserved regions within a state. We believe the policy goals of federally funded GME would be better served by a revised allocation system and urge this committee to consider proposals. We believe this will directly lead to more efficient and effective health care in our rural, underserved region. Thank you again for this opportunity.
Mr. Joslin, last week the committee heard testimony from Mark Miller, the Executive Director of MedPAC, and he testified that increasing residency positions for hospitals in rural areas doesn't necessarily translate into those residents staying in rural areas. My experience has been in Texas, in our district, has been the opposite. Your thoughts, other than increasing the number of slots, what would you recommend to us to do to incentivize physicians trained in rural areas to stay there and practice medicine, because it is just so critical for communities like ours and certainly those on the subcommittee?
Yeah, absolutely. It's such a critical issue because underserved areas are so difficult to recruit physicians to in the first place. Obviously, the economics play a major role in that, and so you have to have other ways to get physicians there. I'm not familiar with the testimony of the MedPAC individual, although my experience has been different. My experience has been when you do provide training and additional training in those areas, a large percentage of those residents do stay. If you look at us, for example, over the last 40 years, we've trained 3,000 residents, and 1,000 of them have stayed in the valley. They don't just stay in Fresno, they stay in these outlying rural areas. We serve a 15,000 square mile radius, a large geographic area, and a lot of that's underserved and rural. And that's where those physicians are staying. And over the last 4 years alone, we've had 120 of those residents stay and practice in these rural areas and stuff. So I would argue that training does pay dividends relative to physicians staying in these areas. At least our statistics show that at least 30% of the physicians that we train do stay in these areas. So I think that's critical. And I do think there are other things and creative ideas that are being suggested in how that we can provide specific training in these rural areas that also supplements the GME slots that are currently available. And it's not just funding additional slots, but certainly looking at the way those slots are allocated within states, which is a huge problem for us. In California, for example, if you look at California, it's relative to the Central Valley, it's very skewed because the Central Valley is the poorest area. As I mentioned earlier, it's about the 5th poorest area in the country, but when you factor in Los Angeles and San Francisco, the numbers are very skewed. And so you have to also then start looking within states and looking at underserved areas within states. And our area is a perfect example. In Central California, we have 48 primary care physicians per 100,000 residents. In San Francisco Bay Area, they have 85. And so obviously there's not the same dire need in the San Francisco Bay Area, and I'm not minimizing their issues by any means. I'm simply saying that when you're looking at how you provide slots, I mean, there's two issues associated with that. Certainly there's a number of slots you provide, but certainly just as important is how you allocate those slots. And really the whole intent of this program is to help get physicians in underserved areas. That has to be a key component of that. And our slots have been capped since 1997, and that issue needs to be respectfully revisited so that these underserved areas like ours can do something, because if we don't, they're going to continue to do what they're doing today, which is just showing up in the emergency room.
Thank you, Mr. Joslin. Mr. Thompson, you're recognized.
Thank you, Mr. Chairman, and thank you to all the witnesses for coming. It's been good testimony, and I know you guys, I've represented a rural area for most of the time that I've spent both in the state and in legislature and in Congress, so I know some of the challenges you have, and my wife's a healthcare provider in a rural hospital in my current district, and so I know very firsthand how challenges it can be. So thank you for helping us understand the problems and trying to figure out some solutions to the challenges that you face. I'm a big supporter of telemedicine and telemonitoring, and I've had a number of pieces of legislation that has helped advance this, and Ms. Black and I have legislation in this Congress to help move that forward again, and I think it's a way we can address a lot of the problems that we face. So I'd like to know how your hospitals are using, if they are using, and if so, how they are using both telehealth and remote patient monitoring. Start with Mr. Joslin there. You don't have to do a thesis, you can just...
Okay, thank you. We're a large safety net hospital, and we work with the rural hospitals closely. In fact, we receive about 600 transfers a month from outlying hospitals. However, we do use telemedicine quite a bit as well. We do it through the University of California, San Francisco, and with their specialists as well. But we've been using telemedicine for the last several years as a key component of the care that we're providing to help rural hospitals and outlying areas and physicians and clinics as well, to extend that to as many providers as possible. Because with what's going on in healthcare, the need for population health, how we look at redesigning the system, it's not just hospitals to physicians, but there's a lot of other types of providers, and telemedicine is a critical component.
Thank you. Mr. Davis, you're recognized.
Thank you very much, Mr. Chairman, and I want to thank all of our witnesses. You know, I was thinking I grew up in rural America, and although I represent a large urban population, I've always had a great deal of affinity and hopefully some understanding of rural America's needs as it relates to health care. In my family, we often discuss the fact that we believe that my mother may have died prematurely because she had to travel more than 150 miles to get to a regional medical center where she could get dialysis treatment. I'm a big fan of regional medical centers like the one, Mr. Joslin, that you come from and represent. But I also recognize that in training, we need to train the best physicians that we possibly can, not only in principles and concepts of medicine, but also there has to be enough opportunity for the individuals to experience disease entities enough times to, I always like physicians personally that I feel have seen a lot of patients like me, and that in the process of doing so probably has a better understanding of whatever it is that I'm there for. In terms of finding a solution to obviously a very difficult problem, we look at reimbursement, and I think that reimbursement rates that are different based upon the complexity of small numbers of people that an entity might be able to see is something to consider. Obviously, telemedicine, as it continues to advance, and other type incentives, how do you feel that these incentives can be tweaked enough or couched enough to really make a serious impact on the ability to recruit physicians and other medical personnel for the rural areas that are having the difficulties we're discussing? Mr. Joslin, perhaps we'll just start with you.
That's a great question. I think there's two parts to that question. I think there's the question of how you tweak the system, but I think you have to start out with the fundamental realization that the system's flawed because the system's just doesn't produce enough. And, we touched on it earlier. We touched on the number of slots, and then we touched on how these slots are allocated. And then trying to provide some type of incentive for physicians to want to go and train in these areas, whether it's financial incentive for educational purposes or however you structure something. But the sheer magnitude of the issue is just the lack of enough slots in these underserved areas that there's really no effective way to move the pieces around until we solve that fundamental problem. And I think we have to be creative to do both, because obviously there's not unlimited resources. We don't have the ability to just keep adding. We have a deficit issue that we need to tackle. And so we need to deal with those types of creative things. And I think those kinds of answers are going to come in the bigger answer of how we're going to effectively redesign this healthcare system to develop a marriage or partnership between those regional medical centers you referred to, safety net facilities, and those rural facilities, and partner with all the other, not only physicians, but other healthcare providers that are out there providing these types of resources there's going to ultimately have to be a different type of system developed so that we can really reallocate resources within a very limited system itself. So,
Futuristic, and visionary, so congratulations. Mr. Pascal, you're recognized for 5
Thank you,
minutes.
thank you, Mr. Chairman, and I want to thank the panel for being so forthright. You know, we need to take the time to read the stuff that gets to us, Mr. Chairman. That's my point, because I think many times, as Mr. Joslin says, we've got to get to the fundamental problems and ones that we do not want to address. So I agree that access to health care in rural areas is an awesome issue. It's worthy of the committee's focus. The state of New Jersey does not have any hospitals with critical access hospital, Medicare dependent hospital, or sole community hospital designations. Mr. Joslin, in your testimony, you painted a good picture of what your hospital's patient population looks like. Despite the fact that your hospital is located in a rural area, it's actually very similar to the patient population at St. Joseph's Hospital in urban Paterson, New Jersey. I compared it. You mentioned high rates of poverty, low education levels, and limited English. Can you discuss some of the challenges associated with this patient population?
Certainly, and your example is absolutely perfect. You know, when you're looking at urban hospitals that are safety net providers in economically challenged areas, it's tremendously difficult to provide all those services that you need. In our area, a third of the adults don't graduate high school. A third. You know, a third of the children in our area are living at or below the poverty level. 20% of the population doesn't speak English. And we're in a huge metropolitan area, relatively speaking, Fresno County and in outlying areas. And there's tremendous challenges. And so we have in common what these rural hospitals have in common are thin operating margins. And we live on the edge from financially because there's not a lot of excess in the system of what we deal with. Same thing that you're dealing with in your area. And so we have to be very efficient. We have to cooperate with others. We have to take an integrated delivery approach to this so that if there are issues with transportation, for example, we can't just admit a patient to the hospital, discharge them and say, okay, now go your way, because there's all these resources out there for you. We have to help provide all those additional resources. You know, transportation, getting them to and from, skilled nursing facilities, home care, hospice, all these things we have to help facilitate as well, because the challenges and we had $180 million last year in uncompensated health care, similar to probably what your hospital.
Yes. Mr. Chairman, just one more statement before I yield.
Briefly, please.
We want to be fair to everybody. I want to be fair to everybody. But I want folks to know I'm never going to vote for any help for rural hospitals unless, instead of going into the pocket we already have, and therefore those hospitals suffering, we need to expand the pocket. We need to expand Medicaid. And that's really at the bottom of many of the problems. You talked about getting to the fundamental problems. That's what I think we need to do. Thank you, Mr. Chairman.
Thank you, Mr. Pascal. Mr. Block, I would point out, I think hospitals are struggling with the $700 billion of cuts to Medicare, you know, many of which landed on our community and rural hospitals. And have been feeling the damage for quite some time. Today's hearing, I understand the point about Medicaid expansion, but the point today was really about listening to specific challenges they face in some proposed bills, bipartisan bills, we hope can help eliminate some of those concerns.
Thank you, Mr. Chairman. I yield back.
Great, thank you. Mr. Kine, you're recognized.
Thank you, Mr. Chairman. Thanks for holding this hearing. I want to thank the witnesses for your testimony, your patience today. And just to follow up on the last point, I'm glad Ms. Black raised this issue. It was actually a question I was going to ask you in regards to the challenges you face with ACOs, the implementation in rural areas. I hail from the state of ACOs. My healthcare providers throughout Wisconsin have been practicing a more integrated, coordinated, patient-centered healthcare delivery system for quite some time. But I'm hearing from my critical access hospitals, a lot of rural providers, that there are some unique challenges that they face with the ACO model, medical homes, that more coordinated care. So anything you can provide our committee to provide some insights. I've been reaching out to my providers back home on this as well. Because clearly that's the direction that the Affordable Care Act is trying to drive the healthcare system to more coordination,
more integration in healthcare delivery services, but there are unique challenges that we recognize in rural areas and that needs to be addressed as well. But let me shift and address a topic that hasn't been addressed yet today. Maybe you might provide some insights. Clearly there's been increased consolidation in the healthcare industry in recent years. We're seeing more consolidation with the bigger providers coming into rural areas, buying up hospitals and clinics. We're also seeing a huge amount of consolidation with health insurance companies right now. Obviously Cigna, Aetna, the latest in the news right now. But wanted to get anyone's reaction on the panel today and these trends that we're seeing, the impact it could have on rural healthcare providers, both the access and the quality issue that you'd like to share with us today.
Yeah, I think fundamentally the problem is the system's fragmented and broke. And I think that you're seeing consolidations not for business purposes, but for patient care purposes. And I think the only way we're going to fix this healthcare system is to partner together and develop new models that are much more effective in treating patients. If you do the same thing over and over and over again, obviously you're not going to get different results. We have to get creative and look to doing things differently. And so what I look forward to sharing with you in the coming months are a pilot that we're doing, for example, where we in a large urban area are partnering with a large provider in the rural area to develop an integrated network with access to care. I absolutely agree with you. Access to care, the primary driver in this, to make sure that there is a system there for everybody, regardless of resources, that's available close to where those patients are and provides the different level of resources they need. But it has to be this new level of partnership if the mission is correct. And the mission has to be access to high-quality, affordable health care. And so you're going to see lots of these models pop up. Some will be good, some won't be so good. But we need to learn from all of them and continue to work towards developing a better model.
I would agree with both those statements. Mr. Chairman, this might be another topic ripe for a future hearing. Is there are large forces taking place in the healthcare field and consolidation, both on the provider and the insurance side in that. We're going to have to, I think, provide more oversight. And then finally, on the training aspect, Mr. Joslin, you talked about the importance of training in rural areas. I know in Wisconsin, this might be true in your areas too, that we're really making a concerted effort to try to recruit in rural areas before even training, because we found if you can get them from the rural community, the quality of life that they grew up in, it's easier to direct them back into those communities to serve and in the healthcare function. So if you've got some unique programs that you've been working on as far as recruitment, we'd be interested in hearing about that so we can kind of take that to capacity. Thank you, Mr. Chairman.
No, thank you, Mr. Kahn. Great, thank you. I'd like to thank today's witnesses for their testimony today and appreciate your continued assistance getting answers to the questions that were asked by the committee. As a reminder, any member may wish to submit a question for the record. We'll have 14 days to do so, and if they do, I'd ask the panel to respond in writing in a timely manner. Again, we're looking for common ground in how we address these rural health care disparities. Today's hearing was helpful. With that, the committee is adjourned.